Good afternoon, everyone, and welcome to Stewarts Soundbites, another 15-minute session. I say 15 minutes, I'm going to try, we're going to try and keep to 15 minutes as much as we can, but we've got so much good stuff to talk about today. It's the 17th of May, and I say the date at the time we're recording because we've just had SCI, we've had Spinal Cord Injury Awareness Day. This is Mental Health Awareness Week, and the topic that we're dealing with today kind of links quite well in with what's going on. So that's why I've said the date, not because I think half of you are asleep and don't know what date it is. So we've got a real treat today. We're so lucky because we've got Dr Jane Duff, who's a consultant clinical psychologist and head of clinical psychology at the National Spinal Injury Centre at Stoke Mandeville Hospital. And Jane, we were just saying before we started, Jane, I just don't know how you do everything. You've got so many roles and so many strings to your bow. There's loads going on. Jane also serves as the chair for the European Spinal Psychologists Association and the ISCOS Psychosocial Special Interest Group, to name a few. Also, you know, actual real life work, mother, you know, all of that kind of stuff as well. And today we're talking a bit about the recently published spinal cord injury pathway and transformation recommendations for adults with spinal cord injury who have psychological and mental health needs. And we see it's such a great topic because we see, you know, from a lawyer's perspective, I suppose, Jane, you know, we have clients with spinal cord injuries, and you see in that kind of acute phase, the most kind of the spinal cord injury takes precedence, and then we've got all of these kind of associated problems that are kind of secondary, I suppose, at the time, and maybe picked up a bit later. And I wanted to talk about how things work at the moment in centres and what the pathway and the recommendations, what they suggest needs to happen, or maybe where it needs to change. So a good starting point, Jane, I've just railroaded you with a whole monologue there, sorry. A good starting point, Jane, if you don't mind, is just to give us a little bit of an overview of the kind of the purpose, the aims and objectives of the proposals and recommendations.
Emma, thank you, and it's a delight to be here, and I'm really grateful for the invitation and the opportunity to share with people and raise people's awareness about psychological health needs. They're generally under-recognised, so that's why it's a brilliant opportunity to kind of connect people with that. The main purpose is really to standardise care across the spinal cord injury centres. There is at the moment very wide variation in psychology and psychiatry resourcing, and so identifying standards, you know, which have been consensus agreed in terms of what those standards should be, will hopefully in time, if we do peer reviews and look at adherence, have a knock on in terms of that resourcing and creating some parity amongst the spinal cord injury centres. In terms of introducing the screening measures, that supports people to identify people who would need psychological treatment, because at the moment most centres operate on a referral model rather than a screen and assess and treat everyone model. There is a difficulty in that there isn't resourcing to do that, but certainly if we start with screening as a baseline, we will begin to identify the number of people, the amount of people who have difficulties on first-time rehab. The recommendations are also that people are screened on discharge, which currently largely doesn't happen, and that's really crucial in terms of signposting people on the services. Okay. And we know that, as you said, first-time rehabilitation is around people's functional needs of you know, mobility, skin, bladder, bowel, all those kind of things. It's not around people's psychological adjustment per se, and there's a lot really, you know, 2, 3, 4, maybe sometimes 5 years post discharge of that adjustment process. And one of the recommendations is that there's regular screening, annual screening of mood after discharge, because there is a difference. Research has shown there's a difference in that 1 year, 2 year period of people who perhaps didn't have difficulties initially, but developing difficulties after discharge and on transition, because there's so many things to make a transition to, really.
Yeah, and we see it all the time, don't we, Jane? Discharge is just monumental process for patients, families, it's a whole, I mean, I'll come back to that, and I'll come back to more kind of substance about the recommendations themselves, because I want to talk about that a bit more. But I wanted just to go back slightly to something that you mentioned there, which was the need basically for these recommendations to be looked at in a kind of more of a pathway to be implemented. And I want to talk about kind of, you mentioned there kind of that some people kind of slip through the net, and any kind of disorders or problems are not identified, or they're under-identified and under-treated. Why is that?
There's a range of things. One is the kind of the referral model approach rather than a screening approach, which is why these are hopefully quite transformative in terms of challenging that. There's a bias that occurs when you use a referral model. There's a clinician bias on the basis of experience, which is partly education, partly knowledge, training, those kind of things. And that's why we have things like breast cancer screening, because screening is the model of healthcare. It's very effective, and there are some kind of biases that do exist in spinal cord injury around whether different levels of injury cope less. It's assumed that people with the higher injuries can often cope less well. But we know from the caudal equina research there's a massive amount of adjustment that's required. Even though people might not be using a wheelchair, because there's the bladder and the bowel and the sexual function. So there's a lot of the psychological variables are actually a lot more predictive of people's long-term quality of life than functional and mobility-based variables. But there's a bias in clinicians assuming people with higher injuries might struggle and cope less well. So there's a huge tendency, and they're also under-recognised, because I think people have a fear of asking generally in mental health services how someone is, or in physical health services about someone's mental health, because of perhaps getting an answer that they might not be able to manage or signpost to, or might get them in kind of deeper water in terms of discussing risk or suicidality, or not knowing how to handle something. And that's something it's a societal problem that we have. And I think that is a barrier also about asking about psychological issues, when healthcare clinicians in physical health are much more comfortable sticking in the physical health domain.
Yeah, which is understandable. Do you think that, I mean, we see so much as Mental Health Awareness Week, we see so much about kind of opening up the dialogue. Do you think that that's helped at all?
Well, it's interesting. I was listening to a podcast yesterday about anxiety, and yes, that a lot more anxiety is certainly in younger people, which is interesting for us as a spinal cord injury to kind of, those people may sustain injuries, and we may need to be aware of this kind of 10, 20 years down the line. But the incidence amongst younger people in terms of mental health difficulties, anxiety, depression, and suicidality is much greater in the last 5 or 10 years than it was earlier. And that's partly through people feeling more open to discuss about their mental health needs. Also partly people asking the questions more. I don't think it's and the podcast was discussing, it's not it's not really related to people kind of exaggeration or things like that, but it's actually people being much less of a taboo and stigma to talk about those issues.
Yeah, it's kind of sad, but also hopeful, that it is more of a discussion now. I wanted just to talk a wee bit, Jane, if you don't mind, about kind of current provision. I know this is almost impossible because you could talk about it all day, and because we've got different centres across England, that all have different, as you say, different resources and different views on things, which vary from clinician to clinician, never mind from centre to centre. But I wanted to talk a little bit about current provision and what the kind of substantive changes are that are recommended. And we'll, by the way, for everyone listening, we will post links to the recommendations, the pathway document, and make sure that everyone can kind of have a good read, because it's absolutely, it is brilliant. But just tell us a wee bit, Jane, if you don't mind, about the current provision and kind of what the substantive changes are that are recommended. I know you've touched on some of them already.
The standards include a complexity pathway, which basically identify kind of foundation psychological health needs, which which everybody should have an assessment. Everybody then should, if their needs are identified, have treatment, and then that kind of screening for discharge. And then layering onto that, there's 4 kind of groups that have kind of been identified, and we've used this at Stoke Mandeville since 2014, and we've done audits on it and reliability and all those kind of things. And so really there are a group of people who kind of have quite highly complex needs, so quite significant mental health needs, perhaps with current risk, perhaps with historical risk, and they are, in terms of the data from that we have at the NSIC, about 12 to 15% of the spinal cord injured population in rehabilitation centres. Wow. And then there's people who, so the intensity is partly identifying in the intensity of support that people would need. And for example, with that group, pre-admission planning, the very significant discharge planning, and a lot of MDT consultation during their admission. And then there's a kind of a group who have clinical levels of anxiety and depression and adjustment difficulties, and would need, psychological therapy and treatment, CBT and that kind of thing. That's quite common and in kind of use in practice. And then there's kind of a group of people who perhaps have kind of quite brief, quite intensive, difficulties, but will only need a few sessions. So there's a whole variety of needs, really, and I think the pathway is trying to identify those, but fundamentally saying that everyone admitted, and it's not just, the crucial thing is it's not just people admitted to spinal injury centres, because the estimate is about 1/3 of people don't make it into spinal cord injury centres. It's trying to say that everybody with a spinal cord injury needs to receive a psychological assessment, needs to receive treatment, or mental health clinician assessment, needs to receive treatment if needs are identified, and that discharge element as well. So yeah.
Oh, it's interesting to reflect upon kind of people who might have significant premorbid psychological problems as well, because do they have, so would there be is that that's obviously captured within the assessment? Is that treated differently? Is there a separate assessment, or is that kind of, is it all built in so that everyone's kind of tested?
So for the pathway bit, it identifies for those complex and highly complex kind of groups where you would refer on perhaps to a psychiatrist, or drug and alcohol services, and things like that, or if there's other kind of neurological difficulties, or traumatic brain injury, where you would refer on to those additional services. And the standards say that there needs to be a documented pathway in spinal injury centres and district hospitals, etc., for that kind of referral process. Yeah.
Okay. And what stage do you see the intervention kind of coming into play? Is it, how early post admission in centres would you hope that this kind of would come into play?
At the moment, because most centres operate on a referral model, people can be referred at any point. It could not necessarily be on first admission in the first few weeks of the spinal injury centre.
Yeah.
But we're hoping with the screening model to identify people earlier, and therefore be able to provide treatment earlier. So really, as soon as someone's assessed as having need, they should be able to have treatment in relation to that. There will be resourcing implications because of the variety across the 8 centres, but it's only really with the screening and with the standards that we can identify where the gaps are, and how to how to kind of address those, hopefully. Because at the moment we don't know. I mean, each centre has kind of data, but actually with the pathway, we know we'll be talking about the same types of people and problems, and what the kind of approach should be.
And how long do you see the support continuing, Jane? I mean, we've talked about already about how difficult discharge can be in managing that, but do you see it as something, the support should be in place for as long as people need it? Is it an ongoing thing? And, what are the practical implications for clinicians and therapy teams that work with someone that have these needs?
In a perfect world, I would say yes.
Yeah.
I mean, we did some research at the NSIC, and we followed everybody up 18 months after they'd left us, and we did the screen measures when they were with us, and then we repeated them afterwards. And so people improved, during the course of their rehabilitation in terms of mood, depression, anxiety, and the adjustment measures. But what we found 18 months later was that they'd actually regressed and gone back to their admission levels of anxiety and depression and adjustment difficulties, the appraisals measure. So ideally, yes, we are very far from that in terms of current practice. And the SIA, in terms of their counselling service, are trying to mitigate that gap to an extent. And the backup mentoring service, which it is mentoring rather than counselling, but also that can pick up on a lot of support, particularly in terms of confidence and those kind of things. But ideally, for me as a clinician, having seen somebody as an inpatient, I would want to be continuing to work on those issues as they transition home.
Yeah. And it's not adjustment, as you say, it's not static, is it? I mean, it's emerging surely with injury and as time kind of goes on. And one thing I always like to talk about, and I think it's important to kind of acknowledge, is the impact upon families as well, kind of psychological impact on families. And I wondered whether they were dealt with in the recommendations. What's the angle on that?
So they're not. So the 10 standards are part of a bigger document. And then the mental health standards kind of operationalize those. But before these came along, the Spinal Injury Psychology Advisory Group had begun work on standards, which is a much larger piece of work, about 100 or 120 we're currently on. And it draws on international research. So we're kind of waiting for the Canadians to finish some of their standard setting. It draws on, Australia, Netherlands, USA, and things like that. So the family aren't specifically spoken about in terms of the ones that have been published currently, but definitely will be in the bigger piece of work. And I would agree with you that individuals adjust to their spinal cord injury in the context of their family, and the family or their social support system, and that's their adjustment has to be encountered, factored in. And also there's a lot of research that people's partners, people significant others, can actually adjust and have more adjust less well and have more mood difficulties than the person with the spinal cord injury, because they're kind of coping and running, as you said, kind of life, as well as a huge change in their circumstance, as well as a lot of worry about their relative or their partner, their friend with injury. So a little plug, if I may, for the ISCOS Psychosocial Special Interest Group pre-conference. It's joint with ESPA, the European Spinal Psychology Association, and it's the day before the main ISCOS conference in Edinburgh. These themes about screening for more than just mental health, anxiety and depression, but screening for adjustment and is one of the talks. Screening for cognitive impairment is another, and there's 2 talks on what people, significant others' needs might be, both in terms of screening and both in terms of The family counsellor, Kim, who works at the NSIC, will be talking about the work that she does with people's partners and families, and how she can support them with her, the kind of difficulties that they might encounter.
Oh, brilliant. That's brilliant, Jane. Thank you. And we'll make sure that that everyone watching this has access to the information that they need and knows where to go. We'll, at the end of this recording, because we are pre-recorded today, at the end of this recording, we'll insert links to everything that we're talking about and direct you to the right websites. And if you've any questions, as always, you can contact me. But it's interesting. I always think it's, it's something that, from a lawyer's perspective, it's always something that needs to be dealt with early doors is family need as well, because often to have the right support for patient or client, you've got to kind of have that backup support for family who are providing the main care, and it's the same for family, isn't it, Jane? I mean, because as much as adjustment isn't standard for a patient, it's not for family either. Coming home and transitioning and having adaptations to the home, or moving, or different levels of care, different times if health needs decline or whatever it might be. It's just constant change and worry.
There is a really nice screen for family members that I use in my medical legal work called the Family Strain Questionnaire. It's one that is a very quick, generally primary care. It's recommended, developed in Italy, but it's English language as well. It's and it identifies whether the family member whether there is a recommendation for the family member to receive psychological support. So it kind of codes that. So that I would really recommend that as a good way of beginning a conversation around what someone's psychological difficulties, where the strain may lie.
Yeah. I know we're running over time, and I know I'm going to get into trouble, but I've still got one more thing that I want to talk about, Jane. Because you have collabed, as the kids would say, on another really good paper about screening measure for anxiety, the GAD-2, and how that applies to people with spinal cord injury. And again, we'll link this paper because it's brilliant. But I wonder whether you could just briefly just kind of tell us a little bit about that and what your findings were.
Yes, indeed. So that so the conversation around that research project came from the ISCOS psychology data set, and the GAD-2, which is just two items. It's really quick to administer, and then there's GAD-7, which is a kind of slightly longer screen, just 7 items, another 5 items. That's part of the psychology data set recommendation measures. Anxiety tends to be, we're poor at recognizing depression. We're even worse at recognizing anxiety. So that's and there's never been a published paper on the GAD in spinal cord injury, and it was ourselves and 2 collaborators in the US that shared our data. And really there's a general population cutoff of 3 or more for the GAD-2, and what we found in our inpatient and community sample from the US was that really there's a recommendation for that cutoff to be lowered for people with spinal cord injury, so that you don't miss people. It's a screen, and all it does is identify that people would need a clinician-led assessment, but there's a risk that difficulties won't be picked up on if there's a higher 3 or above screen that's in the general population. And I am passionate about anxiety being recognised in rehabilitation. I think there's lots of things that will mean we fail to recognise it. People are learning their bladder care, their bowel care. People are learning about mobility. This fear of falling that comes in whether people are transferring to a wheelchair or ambulating. And in the community, people do have bladder and bowel accidents. That can become there can be a whole fear that develops associated with that can become an anxiety disorder, and really be very, very disabling in terms of people not wanting to go out, social participation, quality of life, and everything else. And that starts early on in rehabilitation with those kind of experiences. So yeah, I think certainly screening for depression is really important, but also screening for anxiety, and us turning on our lens around there might be more going on with somebody in terms of them feeling worried and very preoccupied, and it becoming a kind of an ongoing threat and fear, in a lot of physical aspects of rehab.
I think that's really interesting, Jane, saying that we are, not great at picking up depression, but even worse at picking up anxiety and dealing with it is so scary, actually. And I think this is where the slight change in conversation on a societal basis has helped a little bit, because there must be a recognition that, maybe in times gone by, people will have thought, well, depression's something, pretty serious and needs to be dealt with, whereas anxiety is just kind of, you just got to get on with it and just crack on and do your best. But we know how, we now know, and it's much more talked about now, how anxiety can be totally disabling and, can lead to such huge levels of avoidance and, as you say, ultimately impact on quality of life. It's massive.
Yes.
Isn't it scary?
Yes. And I think, there are psychological underpinnings in terms of how your beliefs that you've developed in growing up, your early childhood experiences, whether that kind of sense of threat is greater for people. But I think we've seen in COVID, people largely believe the world is a safe and predictable place, and where people have had difficulties is actually realizing the world is largely that belief, the world is largely, things can happen like a pandemic and can kind of sidetrack us completely in terms of, and that's where we have seen the greater levels of anxiety coming through. So it's people's beliefs about themselves, the world, predictability, what they can manage that can be forerunners to that anxiety disorder, really.
Yeah, that instability. So I'm strongly identifying. It did change everything, didn't it? It changed everything. But I could talk to you all day, but I am going to get in trouble now because we have run over. But I've so enjoyed speaking to you, Jane. You've given me a huge amount to think about, and I really strongly encourage everyone who's watching to read the documents that we're going to post at the end of this recording. Read the papers. They are fascinating, really important, and give you kind of a new way of thinking, or just some additional ideas when you're thinking about structuring rehab programs, or kind of feeding in as a clinician into an MDT, or whatever your role might be. I think it's important for everybody to read this stuff. So please do. If there are any questions rising, please send them to me. I can always touch base with Jane. Jane's absolutely brilliant on Twitter, so I'll post make sure your Twitter handle's on there too, Jane, because there's so much. You post excellent resources, actually, seriously. So people should go and have a look and find stuff. And any questions, please come back to me. I hope you've enjoyed it. I have. As I say, I could speak to you all day, Jane, but you've got things to do, as we know, so I'm going to let you go. But thank you ever so much again for your time.
Emma, thank you. And everybody, I'm really kind of grateful for your interest in psychological health needs, and and recognizing those within the context of rehabilitation. Thank you.
Thanks, Jane. Take care.
Thank you. Bye-bye.
Bye.